Okay, so what I'm going to present, I've tried to reorganize the way the rules are laid out. I'll still give you the rule number so we have that as a reference. I like to look at things as being kind of like a tree, and I'll explain why in a minute. First of all, I tend to think of meaningful use rules as being sort of like a fence. And it's a little bit offensive to us professionals because they treat us like cattle, you could say. I should say here that any of my sarcastic comments are purely my own and do not represent the organization. I'm just trying to be a little humorous. But they're designed to keep us within the bounds of what somebody else considers the best possible practice. Maybe a fairer way would be to think of them as being like a pilot's checklist, to create a system that makes it hard, if not impossible, for us to omit doing certain things, such as asking about smoking each and every time we see a patient. Some folks lament that computers are supposed to make us more efficient. Others say, no, they're to be used as a tool to make us do more. Some point out that it's hard to see how the electronic record is creating better care. Part of the response is that we're still building the tool, not just FHM, but the entire country. So, we had stage 1, which is just getting our feet wet. Stage 2 is getting in up to our hips. Stage 3, theoretically, which by the way, nobody has seen, will be when we start actually using the electronic record to somehow make better care for our patients. Now, there are 17 core rules, and then there are 6 more menu rules. The way meaningful use works is that to pass, you have to meet every single core measure. You can't get 16 of them right and expect partial payment. You have to get all 17 of them right. You also have to choose 3 of the 6 menu items, which we'll talk about too. This is just for fun. This is a recipe for cookies and brownies taken from the Army. Somebody pointed out right away that the first thing they did is they spelled chocolate wrong. Secondly, you can't see it here, but this is a 26-page document. So that's kind of a typical government thing. Whereas your mom taught you how to bake cookies and she put the recipe on a 3x5 card, the government's going to do it the long way around. And that's what they're making us do with electronic records. One of the first and most fundamental things is that you have to have an electronic record to begin with. So you might laugh, that seems obvious. But a lot of the things I'm going to describe, we could say we were already doing that on paper, or we could do that on paper, and that doesn't count. So no matter how good a system you have, the government's not going to pay unless it's done with an electronic record. Furthermore, it has to be certified software. What does that mean? Well, there's an independent organization that okays the software, and this could be a potential problem for us. Stage 2 rules were not out when we made the decision to purchase MedHost. MedHost, is the record we use in the emergency department. MedHost, the company, misread, basically, some of the rules, and they thought that stage 2 was being postponed by a year. That's not correct. It actually is being extended by a year. So they thought they had an extra year to get certified. They're not certified. They're rushing to do so. So we are working with our attorneys to see how much of a problem that is and what remedies we have. Next, and these are all behind the scenes things, so that's why I put this down with the roots of the tree. We have to protect electronic health information created by the EHR technology. You'll notice I put the numbers for the rules here. So when I've displayed it this way, 7 means it's rule number 7 on the hospital side, 9 means it's rule number 9 on the practice side. And you'll see that throughout. That's just there for reference, so when I presented this live in front of an audience, if anybody had questions, I'd be able to open the book to the right rule. Right, now we're moving up the trunk of the tree. It's about functionality, but still things that maybe the provider doesn't have to touch. The electronic record has to be able to create reports. Last year in stage 1, it had to create some simple reports. For instance, if I wanted to look up everybody that had epistaxis, we can do that. We can run a report. Now the reports get more complicated. So you might want to see everybody that had appendicitis who also takes Flonase, because you have a theory that there's a connection. So, theoretically, right now, any of us could ask for reports. If you're curious and you want to look something up about all your diabetic patients, we could run those. This is a yes-no item, meaning that when we file our report to the government, we just tell them, yes, we can do this, no, we can't. Obviously, if we say no, we're going to lose. And we do actually run reports to prove that we can, and keep those on file. Here's a new one. We have to provide patients with the ability to view, download, and transmit information from the hospital or office records. This is a core measure. We have to do it. So this, in other words, is our portal. We've been working on this diligently since before 2013, and even more diligently since January 2013. Had some hang-ups. The portal's there. It's installed. We're going to have a soft live in May, and then fully live by July 1st. Let's talk about the fiscal year. For our first year of Stage 2 Meaningful Use rules, we have to get them right for a calendar quarter. The hospital's fiscal year started October 1st, so that calendar quarter is over. As I dictate this to you, it's now March 29th, so the second calendar quarter is over. We don't have the portal up and ready, so we're not going to be able to do this in the third calendar quarter. We have to do it in the fourth. Otherwise, we lose all our incentives for the year and get into payment penalties. What kind of stuff goes into this? Tons of stuff. The patients are going to be able to look up, their diagnoses, and those who cared for them, their medications, the rest of their discharge instructions, like activity and so on. There's some things that we would expect the patient to know, like their birth date and their gender, but the government says we have to give them a chance to look that up too. I think that's kind of funny. And where does this information come from? Well, we have to put it in there, and this is part of the discharge routine, so that when we're filling all that stuff out and you're wondering, well, where does this information go, we're doing that to meet this particular rule in large part. We have to incorporate clinical lab results. This was one we thought we were doing really well, and now we are reconsidering. And certainly it's true to say that essentially almost 100% of our lab results are in the electronic record. The tricky thing is how well are we getting those lab results to non-FHN providers in an electronic way. And we have gone back to the drawing board since I made this slide to see if we're getting that right. Apparently transmitting the lab results from the hospital lab to my office, we've learned, doesn't count because it's not really a transmission. We're merely making them available to me since I'm already on the same computer system as the hospital. So rather than being able to count the majority of labs with the majority of FHN providers, it looks like we might have to measure this thing on the margin for the people that are outside of FHN. Very challenging, very tricky. I'm worried about it. I've stepped away from the tree because the record has to communicate outside of itself. We have to have the capability to submit data to immunization registries. Also to electronically submit reports, lab reports to public health agencies, and to submit syndromic surveillance data. That would be things like number of episodes of flu going through the community at any given time. We have to provide a summary of care record upon transition of care. So transition of care is going from the hospital to the nursing home, or from FHN Memorial Hospital to RMH, or going from the hospital to home, or going from Dr. Schleich's office to my office. Once again, one of the challenges is since we are all on the same system, we are afraid that it's not going to count when the records from the hospital go to Sandra Jackson's office. We think it's only going to count when the hospital records go maybe to Michael Muse's office in Monroe. The rule sounds simple. We have to do it in some form or another 50% of the time. But that 10% of it has to be done electronically. Well, that means we have to have somebody trained to do that electronic transmission. And also somebody on the other end to receive it. A lot of our patients go to nursing homes, and they're trying to get electronic, but we're hoping they'll be ready in time to receive these documents. Another big challenge that has me awake at night. This one I think we're okay on. It's a new measure, but it talks about tracking medications from the time they're ordered until they're administered using assistive technology. In other words, electronically ordering the medication, the pharmacy handling everything electronically, the nurse at the bedside using the barcode reader on the patient's wristband to be sure she's got the right patient and the right drug. So here's one I'm fairly comfortable with. Implement clinical decision support. This takes some different forms. For instance, in the hospital, you admit a patient, you determine they have community-acquired pneumonia, you pull up the appropriate order set for community-acquired pneumonia. That order set already has on there a few antibiotics that are appropriate, and it doesn't list antibiotics that would be inappropriate. So that's clinical decision support. We're still figuring out what that's going to look like in the office. But in other words, it's something to guide us so that we're just not relying on our own memory and training and reference books. Use clinically relevant information from the electronic record to identify patient-specific resources and provide those resources to the patient. Well, what this means is that you have an inpatient and you've entered congestive heart failure as the diagnosis. Well, the computer needs to clue you in to say, gee, we should give the congestive heart failure pamphlet to this patient when they go home. Similar thing in the office. We're moving up into the branches of the tree, and eventually we'll get to the leafy part when I consider the real benefits of the tree, the part that provides shade and fruit and curb appeal. We're not there yet. We have to record demographics. Another one, thank God, that we're meeting virtually all the time thanks to registration and our PSRs and so on. Demographics is really a very long list of things, more than just your name, address, birthday, and telephone number. But we are collecting that information. They made a little change in the rule. Last year we had to record patients' gender. This year we have to record their sex. Hopefully it won't change for too many patients. Provide clinical summaries of the office visits. Well, we've been doing that. Those are those papers that your PSR or somebody else, I know some of the providers are doing them themselves, are handing to the patient at the end of the visit, or at least mailing them within the next day. There's a time limit on how quickly they get them. Now that we have a portal, we'll be able to get rid of some of the paper unless patients want the paper report, in which case that's what we have to do then. But it's still the same concept. In other words, if I don't have my diagnosis and my prescriptions in there within a certain amount of time, and it's not viewable to the patient, that doesn't count for meeting the measure. As we go, you'll notice that some of these measures have a percentage attached to them. This one, for instance, we have to at least 50% of the time. 49.97 doesn't count, means you failed the rule. We generally have not advertised the percentages because, first of all, they're different for every single measure, and they're darn hard to remember, which one is which, even for those of us that look at these things every single day. Secondly, if I say to myself in my office, okay, I only have to do this half the time, and I shoot for half the time, then there's a real risk I'm going to get it 49% of the time and lose. Or I could try to be really accurate and tape up a sheet above my desk where I keep track of how many patients I've seen and how many of them we did the summaries for. I'm also going to have to track that for umpteen other items. And I think that creates as much, if not more, work for me than just trying to do it all the time. So if I try to do it all the time and I occasionally slip and get it right 98% of the time, that's not too big of a sin. If I shoot for 50% and I slip and I lose the meaningful use, that's a bigger sin. Record vital signs. Well, to you and I, vital signs might mean something different. For instance, somebody comes in sick with the flu, you'd like to know their temperature, their pulse, as well as their blood pressure. The government specifically is talking about blood pressure, height, and weight. And I believe this is in part because obesity is a nationwide epidemic. And I believe that someday they will maybe adjust our payment depending on how obese our patient population is. So we're creating a database for them to be able to track someday, I think. But that's what vital signs are to the government. Fortunately, thanks probably mostly to our nurses, we're hitting this virtually 100% of the time. Record smoking status. There again, I suspect a day will come where if we have a large number of patients that smoke, we might get penalized in how we're reimbursed. Once again, this is something that our staff gets most of the credit for, but we're doing a pretty good job at it. This is not to say that we did not do a good job before. I think we all saw patients, counseled them about their smoking, but maybe didn't do it absolutely every time. Now the record makes it hard to get away from doing it absolutely every time. Computerized physician order entry. Well, we started doing this in the hospital in May of 2011, so we've been doing it almost 3 years. We're doing great. In the offices, we all started at different times, but most of us are doing well. This talks about not only ordering medications, but also labs and imaging. This slide is several months old. We're virtually at 100% for the offices now, except for family counseling, who's starting soon. E-prescribing. Well, this used to confuse me. This is separate than ordering the medication. It's one thing to order the medication, and it's another thing to electronically transmit it. And so this measures how often do we electronically transmit it. We're doing pretty well with this. Medication reconciliation with each change in the setting of care. So, in other words, patient going from the ER to the inpatient hospital, patient going from the hospital to their primary care physician's office, patient going from one physician's office to another. Those are all changes in the setting of care, and we're required to check the medication reconciliation each time. Some practices have a little trouble, but overall, most are doing great on this. Once again, credit probably goes to the nurse. I realize that providers check the meds too. I don't mean to imply that they don't. Secure messaging. This is a brand new one. This is the one that I worry about the most, even though it sounds simple. This is strictly an office thing, not a hospital thing, but it says at least 5% of each provider's patients have to send the provider an electronic message. Sounds easy, right? It doesn't count if I send a message to the patient. It does not count if the patient sends me an email with my regular work or home email address. It only counts if they get into the portal and then send me a message. What am I worried about? Well, first of all, we'll need to learn how this is going to work, and we're still working out the details. Is that message going to go to my PSR? Is it going to go to my nurse? Is it going to go straight to me? I think we're all used to our nurses fielding refill requests and appointment requests and things like that. And if all those things come straight to my desktop, that's not going to make me happy. But that's not the real issue. My real concern is, how are we going to get people to do this? Yes, we're going to have incentives. We're giving away iPads or Kindles. So folks that use this feature get put into a lottery and might win a prize. We're going to have to tell them all about it. Here's something that the government completely got wrong. For the first year, we've already discussed that we only have to meet stage 2 meaningful use for a calendar quarter. In other words, July, August, September. For the second year, we have to meet it for a whole year. That means that we have much less time to get 5% of our patients to send these emails. And it only counts on the patients you see during that 3-month period of time. So in other words, for each patient that you see in July, August, and September, 5% of them are going to have to send you a secure email. Now, here's another thing we haven't dwelt on so far. In the hospital, we earn our meaningful use credits by working as a team. In our practices, we earn them individually. And by individually, I mean, not that any one provider has done it all himself or herself, but rather it's all based on that provider's name. So, let's say Highland View Drive, merely as an example. 6 providers there. 5 of them might do absolutely everything perfectly, 1 doesn't. Well, the other 5 don't carry the 6th one. The 6th one just loses their meaningful use rules. Highland View Drive is going to do fine. I just use them as an example for numbers. But the point is that these electronic messages have to be reproduced over and over again for each provider. So, any given patient, maybe they're seeing Dr. D. Domenico, they're seeing Dr. Amy Asawi, and they're also seeing Dr. April Moore. Well, 5% of each of their patients have to be sending them emails. I don't think it's going to count if one of those shared patients sends one email. I think this is a really tough rule. We have to send reminders to people. Here's another one that sounds easy on the surface. As you dig into it, it's not so easy. This is a brand new rule. So it says 10% of the patients that were seen at least twice in the previous 24 months have to get a reminder. Now, what kind of reminder? Let's say I have an appointment scheduled next week with Alan Workman. His office already calls me. They say, hey, you've got an appointment coming up. I appreciate that. That doesn't count. This does not count for things that are already scheduled. This is more to remind people to do those recurring things that they need to do, like their colonoscopy every 10 years, or mammogram or PAP every 1 year, or whatever the rules are now. The flu shot annually. All right, it still doesn't sound too bad, but remember, we're going to be measuring this during July, August, and September. Is that too early to send the reminders for the flu shots? Colonoscopies, maybe they're only done every 5 or 10 years. How many people are really going to need to get this reminder during that period of time? Certainly the 20, 30, and maybe 40-year-olds don't need to get it. So I think we're really going to have to scrape to be able to be sure we get enough of these reminders out. There's been a subcommittee that's been meeting for months on this, and a lot of it's worked out actually. But you'll start hearing from your patients soon. hey, I got this notice on the portal, or I got this thing in the mail. Patients have the right to choose which way they get it. They can also get their phone. So I want you to be aware of that. I'm going to keep moving here. These are menu items. Remember we said before that in addition to all those core measures that we've already discussed, we have to choose 3 menu items. Now I've kind of jumbled them together here because this was originally a presentation for a different group, but some of these menu items are for the hospital, like advanced directives, and we'll meet that one. Electronic progress notes. Well, that's both hospital and office, and that's the PDOC in the hospital. We're doing that. We've got that one made. Images embedded in the electronic record. That's both hospital and office. And that just went live a couple weeks ago. Yes, it needs some fine-tuning. Basically, the functionality is there. Family history, also measured on both sides. We decided not to pursue this. Why not? Well, first of all, every family history that you've already taken the time to record, since you went live, isn't going to count because the government created a new way of recording it. I'm not too fond of their new way, by the way, but that's just my opinion. So to meet this measure, we would all have to take the family histories over again. Furthermore, to hit the goal, there are not enough hospital admissions to meet the goal. When we're judged at the hospital, we're judged both on the hospital admissions and the ED visits. So for some goals, for most, we have to have this performed both inpatient and in the emergency department. And typical emergency department visit, they might ask you, as you're lying there with chest pain, anybody in your family have heart trouble, but generally it's not the nature of their practice to take a detailed family history as you might as you get a new 60-year-old patient, for instance, in the office. So it sounds simple, but we thought that was one of the ones we could easily fail at, and that's why we didn't pursue it. Lab results to ambulatory providers, we touched upon that earlier, where we thought we were doing well, but now we're not so sure if we're going to get measured on how well we send lab results to people that ordered in from Rockford and Monroe and so on. We might have some troubles. Submission of syndromic surveillance data from the offices. I don't think we're set up to do that. Likewise, cancer registries. Likewise, specialized registries. For instance, if there's a registry of everybody with a certain kind of trisomy, we'd have to get enlisted to participate in that. So some of these menu items are tough, and I'm glad we only have to adopt 3 of them, but even the ones we do adopt are challenging. Well, that's all I have to say today. You've been very kind to listen this far if you have, and I'm certainly open to questions. I know recently there's been some conversation about just adopting the sort of the bare minimum we need for meaningful use, and I'm not saying that there might not be room for trimming, but I think you've seen too that the bare minimum is still quite a lot, still very much that we have to do. Remember that stage 3 rules are out there in the future. Nobody has seen them yet. I think stage 1 to stage 2 is a big leap, much harder. And I predict that going to stage 3 is going to be harder still. We've talked about why we do these. Yes, it's for better patient care because hopefully we're going to get more people back for their colonoscopies, and hopefully we're going to talk some more people into quitting smoking because we remember to ask them each time, and hopefully we get patients to lose weight because we talk to them about that at every visit. So patient care is the real reason for doing it. But the penalties that we're trying to avoid are also very important and not insignificant reason. Again, thanks for your time.